Hi, I'm Dr. Hudson Nakamura, a retina specialist. I'm going to show you a very interesting case on a complex retinal detachment. This pseudophakic patient had this recurrent retinal detachment and was referred to us for fixing it. So as you see here, there was a tear in the inferior retina caused by a retraction from retinal detachment and the subretinal fluid reaching the macular area all over. And the retina was actually held by old laser marks from the previous surgery. In this case, it was necessary to release the retina 360 degrees, and you see here the cysts underneath the retina. So the action is to release it all over and doing retinotomy as far as possible at the very periphery, preserving the macular area. In this case, the retina was detached and the scars, the laser that you see there is actually pulling on the retina, at the temporal part of retina, at the macular area as well. So the best choice here was to relieve it all over 360-degree retinotomy, and using perfluorocarbon liquid, as you see here, the retina is going to get attached, of course. And how much of PFC you have to use, you have to fill it up to the retinal periphery in the old ora serrata, and start the laser very peripheral in order to attach the retina. Maybe 2 or 3 rows are usually necessary. Otherwise, the retina won't get attached. In this case, it was pretty good. We removed all retina tissue and the retractions that were at the very far periphery, and now everything is attached. So doing laser under perfluorocarbon liquid, in this case, perfluorocarbon liquid has a very good surface tension, allowing for good visualization and laser marks. You see here the very far periphery of retina, how much tissue was removed in order to get this retina attached. I'm filling up a little more of perfluorocarbon liquid in order to reach far periphery. And the interesting now, and the best guess is to do next step is a direct exchange of perfluorocarbon liquid for silicone oil. Otherwise, the retina could probably have some slippage. You see here 5,000 centiskotox silicone oil coming in. At the same time, the perfluorocarbon liquid is removed. This is the direct exchange. And by doing direct exchange, the silicone oil reaches far periphery, and you see the macula is beautifully attached. But sometimes, even though you attach the retina, the silicone oil is just there in some pseudophakic patients, and even patients aphakic without the intraocular lens, some silicone oil might get at the far periphery and get actually passing towards the anterior chamber. If that ever happens, the good thing is to remove the remaining maybe some droplets of silicone oil at the anterior chamber, just like that. But you have to stay inside the silicone oil bubble. And you see here it coming in, and you use the cannula to remove it all. And if there is some little droplet of silicone oil, the head position will take care of that. And removing sclerotomy is here, and the patient gets attached. Thank you very much for your attention.